Welcome back, and once again a very good evening to each and everybody. This is teleconferencing program, and this program is based on 5 sessions. This program is specially meant for DNB students, and this is our second last session of today's program. The topic of this session is non-invasive and invasive ventilation in acute exacerbation of COPD, and we have in our studio as our expert Dr. J.C. Suri, who is senior chest physician and head department of pulmonary critical care and sleep medicine, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Besides this, we also have with us in our studios Dr. T.K. Jaina, who is from School of Health Sciences, Indira Gandhi National Open University. This program is for DNB students, and if you have any queries about non-invasive and invasive ventilation in acute exacerbation of COPD, you can make a phone call and ask your queries from Dr. Suri. Dr. Suri will answer your queries. The numbers are 011, which is our STD code, and numbers are 29532844, 29532845, and you can use our toll free number also, that is 1800112345. To download the forms of National Board of Examination, you can visit our website. The website is www.natboard.edu.in. I spell out www.natboard.edu.in, and to get the DVDs of teleconferencing programs, you can contact National Board of Examination. This program is jointly conducted by Indira Gandhi National Open University and National Board of Examination, and we have one more information for our CME workshops for DNB students and consultants. That is, in order to sensitize the DNB students and consultants, some CME programs would be organized, and the programs are CME programs in preparing for theory examinations, CME programs in preparing for practical examinations, CME programs in preparing for thesis research methods, CME programs in clinical and surgical skills for DNB candidates in surgery, OBG, orthopedics and anesthesia only, and CME workshops for consultants on bedside teaching, research methods and evaluation. The concerned students and consultants are required to apply for these CME programs immediately on the registration format available on website, along with the registration fee, by 28th February 2009. And the centers for these CME programs or workshops would be in New Delhi, Chennai, Hyderabad, Bangalore, Kolkata, Calicut and Pune. And one more information for you, that the topic of our next week's teleconferencing program, which will be held on 12th February 2009, is radio diagnosis and neurosurgery. That is of next week, but right now in our today's teleconferencing program of in this session, the topic is non-invasive and invasive ventilation in acute exacerbation of COPD, and I would request Dr. J.C. Suri to start the program. Dr. Suri, please.
Good evening, ladies and gentlemen. At the outset, I would like to welcome you all to this teleconference jointly organized by National Board of Examination and Indira Gandhi Open University. Today we are discussing on various aspects of chronic obstructive pulmonary disease. So far you have had 3 lectures on this, and we have discussed on various issues regarding definition, etiology, clinical presentation, diagnosis and management of chronic stable COPD. You have also had a talk on the general management of acute exacerbation of COPD. Now, as you all know, that when a patient with COPD develops acute exacerbation, he usually presents with features of cardiopulmonary failure. Dr. Gupta had already discussed with you the various aspects of cardiorespiratory failure, that most of these patients present with acute dyspnea. They are usually in type 2 respiratory failure. They are hypoxemic and hypercapnic. Many of them may have respiratory acidemia. The underlying cause can be infections, it can be congestive cardiac failure, it can be any of the complications like pneumothorax, pulmonary embolism and many other conditions, or it can be a combination of these which can result into sudden decompensation of these patients with COPD. You have already been told about the management of hypoxemia with oxygen therapy, the various precautions which one has to take while giving oxygen to these patients with high flow system. You have also been told how to treat the airflow obstruction in these patients with inhaled or nebulized bronchodilators. You have also been told about the management of infection with antibiotics and also the treatment of cardiac failure and other measures like intercostal intubation, drainage in case there is a pneumothorax and other conditions. What I am going to do now is to further further go into the management of these patients. You know that with the best of these conservative management, that is oxygen therapy, bronchodilators, antibiotics, many of the patients still continue to deteriorate. Their dyspnea worsens, they become more acidemic, their carbon dioxide starts increasing, they become more narcotic, they become drowsy, unconscious and comatose. Now, if you look into the natural history of deterioration, then you have type 2 respiratory failure, you have hypoxemia, hypercapnia and acidemia, then patient gradually become drowsy and comatose. So before patient becomes drowsy and comatose, a situation in which most of these patients needs to be intubated and mechanically ventilated, there is a phase when patient can be managed with non-invasive ventilation. So to treat hypercapnia, to treat acidemia, we have two modalities, that is non-invasive and invasive mechanical ventilation. We all know that invasive mechanical ventilation is associated with lot of complications like complication related to the endotracheal tube, such as injury to the larynx, trachea and the bronchial tree. There is also an increased risk of infection in the nose and nasal sinuses in case the patient is intubated through the nose. The high pressure ventilation is associated with lung injury such as volutrauma or barotrauma in the form of pneumothorax. Because of the increased intrathoracic pressure as a result of mechanical ventilation, many patients may develop decreased venous return. With the result, they may develop decreased cardiac output, hypotension and shock. There are other complications of infection, secondary infections, particularly ventilator associated pneumonia and various psychological problems. The other issues are related to oxygen toxicity in case we are using very high oxygen, and also the nutritional problem these patients may develop in case the mechanical ventilation is continued over a prolonged period. Now, if this patient is treated with non-invasive ventilation, many of these complications can be avoided. Not only that, there is a much more improved patient comfort. Patient is able to speak and eat comfortably. He is also able to protect his upper airway because of the presence of cough reflexes and other upper airway protective reflexes. So there is a decreased chance of aspiration and development of ventilator associated pneumonia. Most of the patients are when they are on invasive ventilation, they require sedation, which can cause lot of complications like constipation or gastrointestinal problems, or there is also an increased risk of aspiration. Nutrition can be very well controlled in these cases. Of course, there are limitations when we are using non-invasive ventilation. The patient needs to be conscious, patient needs to be alert, patient needs to be cooperative and able to cough and remove secretions, because we do not have a direct access to the airway of these patients. So the most important advantage of invasive ventilation is we have a direct access to the patient's airway through the endotracheal tube, and we can suck out the secretion. And if the patient has good cough reflex, patient is alert and is able to take out the secretion, then non-invasive ventilation may be a best modality for these cases. So before we talk about non-invasive ventilation, it is important to answer few questions. First, who should be treated with non-invasive ventilation? Because as I mentioned, there are three ways we can treat patients with acute exacerbation of COPD. The conservative management, which Dr. Neeraj Gupta just discussed with you, or we can use non-invasive ventilation, and third is the invasive ventilation. Non-invasive ventilation is probably should be used at a stage when the patient is not very severely ill, and he is either he can be managed with the conservative means, or if you find that there is a gradual deterioration and yet the patient has not reached a situation where we should conventionally treat such patient with invasive ventilation, that's the time I think we should use non-invasive ventilation, because this will not only stabilize patient's physiological condition, but it will also prevent the patient from going into invasive ventilation. So who should be treated? Then is, when we are using non-invasive ventilation, is non-invasive ventilation as effective as invasive ventilation? If that is so, where should we use this modality? Whether it should be used in the intensive care unit under the supervision of trained doctors and nurses, or it can be given in the emergency rooms, in the casualty, or it can be even given in the general ward. We will be talking about that. And how should it be applied in terms of the technical aspects of giving this. So as I mentioned to you, any patients with acute exacerbation of COPD who presents with acute dyspnea, whose respiratory rate is more than 28 or 30, whose PCO2 is more than 45, that means he has gone into type 2 respiratory failure, and pH shows acidemia, that is less than 7.3, and this is despite adequate and optimal conservative management. I think we should consider to use to treat this patient with non-invasive ventilation. I would like to add here that most of the trials which have been conducted so far to study the role of non-invasive ventilation have used these criteria in their patient. When you are treating this patient with non-invasive ventilation, you are basically using an interface in the form of mask rather than the endotracheal tube. Now you know that there are different types of masks which are available. We have the nasal masks, we have the oronasal masks, we have total face mask, and we have the hoods. Now nasal masks ideally should not be used in acute condition. They are best suited for giving non-invasive ventilation on long-term basis in patient with chronic respiratory failure and those who requires nocturnal domiciliary mechanical ventilation, say for chronic COPD, chronic stable hypercapnic COPD, or patient with obesity hypoventilation. These are the patients who can be treated with nasal mask. But most of the patients who come with acute exacerbation of COPD, I think oronasal mask or the total face mask is the interface of choice, because this is not only more effective, but it is much more comfortable, and there is a decreased risk of air leaks, and with the result the efficacy is much more. Although when you are using oronasal mask, there are two risks, important risks. One is that of asphyxia should there is a power failure, or there can be aspiration in case the patient vomits, because many of these patients may develop gastric distension because of aerophagia and they can vomit. So the mask should have the facility of asphyxia valve, and they should also have a system, so the quick release system, so that in case the patient vomits, it can be easily and rapidly removed from the patient. Those patients who are drowsy, who are unconscious, ideally should not be ventilated with the oronasal mask, because they may not be able to prevent aspiration. So this patient requires a good supervision by the attending staff in the form of nurses or doctors when you are treating such patients with non-invasive ventilation. Is non-invasive ventilation as effective as invasive ventilation? What do we mean by this? When we say if non-invasive ventilation is more effective or as effective as invasive ventilation, that means it should result in improvement in gas exchange. That means there should be improvement in the oxygenation, There should be improvement in the ventilation with the fall in carbon dioxide level. There should be improvement in the acidemia. And by doing so, we should also be able to unload the respiratory muscle. The patient should feel that there is a decreased work of breathing and they should have less dyspnea. And this will be shown by decreasing respiratory rate. So if you unload the respiratory muscles, if you take care of the work of breathing, you will be able to increase the tidal volume, and with the result the respiratory rate will come down. Then it should result in, if this is so, then it should result in prevention of invasive ventilation and avoidance of endotracheal intubation. If non-invasive ventilation is effective, then it should also be associated with less nosocomial infection. It should decrease not only the ICU length of stay but the hospital length of stay, and overall it should result in decrease in the mortality rates. Now let us see from the literature whether we have been able to achieve these parameters with non-invasive ventilation. Now there are a number of studies, randomized controlled trials which have been used, which have been conducted from early 1990s to study the role of non-invasive ventilation in acute exacerbation of COPD. You can see here in these studies that in some studies they have taken even patients other than COPD like congestive heart failure, asthma, pneumonia and pulmonary embolism to treat acute respiratory failure. But most of these studies have included patients with COPD, and you can see from this that most of them have the results in these studies have been a significant improvement in the respiratory acidemia. There is an improvement in the gas exchange. There is a decrease in the endotracheal intubation rate, decrease in the hospital stay and the ICU stay, and overall it has resulted into significant reduction in the mortality. If you look into the results in this bar diagram, you can see that various studies which have been conducted from 1990 onwards by Brochard, Vitica, Brochard, Kramer, Wysocki and Confalonieri, you will see that in most of these cases, as you can see, that there is a significant reduction in the intubation rate as shown in the red bars against controls. If you look into the mortality, again you can see that there is a significant reduction in the mortality of this. If you go into the meta-analysis of these studies, you will see again looking into the odd ratios here that non-invasive ventilation is associated with decreased need for endotracheal intubation. You can see here the odd ratios here, particularly it is quite significant for patient with COPD as against when you are taking for all patients, and non-invasive ventilation is also associated with decreased mortality. As you can see that the odd ratios are much better for COPD patient as against when we take all other patients. This is a very important study which has particularly looked into nosocomial infections in patients who were critically ill, and this is also a controlled study where 50 patients with COPD or cardiopulmonary edema, most of them were hypercapnic, were compared with the 50 patients who were treated with invasive mechanical ventilation. And you can see here very clearly that those who were treated with non-invasive ventilation had significantly less nosocomial infection, less antibiotic use. There was a significant less duration of ventilation days. You can see 6 days versus 12 days. ICU length was also shorter, and the crude mortality, as you can see, was significantly less in patients who were treated with non-invasive ventilation. If you want to look into different types of nosocomial infections here, as you can see here, nosocomial pneumonia, urinary tract infections and catheter related infections again were significantly less in patients who received non-invasive ventilation than those who were treated with conventional mechanical ventilation. Looking into the overall the cumulative proportion of patients who are remaining free of nosocomial infection, again you can see here these Kaplan-Meier curves, you can see here that those patients who received non-invasive ventilation had significantly less nosocomial infection as comparison to those who were treated with conventional ventilation. The rates of nosocomial infections were much better than those who received non-invasive ventilation successfully as comparison to those who showed non-invasive ventilation failure. The long-term survival also was much better in patients who received non-invasive ventilation as compared to those who were treated with invasive ventilation. It has been seen that once a patient has been ventilated with invasive ventilation and he comes out of that ventilator, there is a permanent damage to the respiratory system. They never recover back to their original baseline lung function. So there is a significant deterioration in their baseline lung function, which we see with the invasive ventilation as comparison to those patients who are treated with non-invasive ventilation. If you look into the cost analysis, as you can see in this study which was conducted by SEEN, the overall expenditure, if you take costs, the hospital cost which is incurred on these patients when they are treated with non-invasive ventilation, was significantly less than those who are treated with invasive ventilation. So to put together, looking into the benefits of non-invasive ventilation, what we have seen from the literature and from the important randomized controlled trials, that NIV intubation, hospitality, it also results in rapid improvement in the gas exchange in the form of improved oxygenation and decrease in the carbon dioxide level, improvement in their acidemia. There was a shorter hospital stay and significantly less complication in the form of nosocomial infections. The modality, it was found to be tolerated by majority of these patients. 80% of the patient could use these non-invasive ventilation quite satisfactorily with very few side effects. The improvement of gas exchange was much better than the medically controlled patients. There was also a significant reduction in the respiratory muscle work, as seen by the use of accessory muscles, as seen by the esophageal pressure monitoring which these patients generate while ventilating without these non-invasive support. There was an improvement in the respiratory acidosis. Now, as we see that even if the minute ventilation does not improve with non-invasive ventilation, there is still a significant improvement in the respiratory acidemia, and this is because of decreased workup breathing. This is also because of decreased oxygen consumption and decreased carbon dioxide production by the respiratory muscles. Now, when we use non-invasive ventilation, it does not mean that it will be successful in every patient. There is a significant number of patients who may fail non-invasive ventilation and may actually require invasive ventilation. In fact, if we understand this very clearly, then we actually need not put many patients on non-invasive ventilation when they actually require invasive ventilation. So if we put a patient on non-invasive ventilation when he actually requires invasive ventilation, we may be actually delaying invasive ventilation, and with the result we may cause more harm in the form of crash intubation and more complication. So it is very important to understand that which patient should be put on non-invasive ventilation, and there are certain parameters which predict the success of non-invasive ventilation. In one of these studies which you can see here by Ambrosino, who studied retrospectively 59 episodes of acute exacerbation in 47 patients, and what they found that the parameter which they used for success was the avoidance of endotracheal intubation, the complication rates, and they also use certain baseline parameters to predict the success of non-invasive ventilation. And what they found that COPD is associated with the best results, number one. And the other thing which they found that non-invasive ventilation was much more useful and successful in patients who were not very sick. That means those whose baseline clinical and blood gas parameters were showing less severe acidemia and hypercapnia. So the initial predictor for success are initial PCO2, initial pH, and the next thing is the response to treatment. Once we put a patient on non-invasive ventilation, we must re-evaluate these patients within 2 to 4 hours. Those patients who show a significant improvement in their gas exchange in the form of better oxygenation, better pH changes, those who show significant reduction in their respiratory rate at the end of 4 hours are the one who are likely to succeed. Those patients who do not show any significant change or those who deteriorate, whose respiratory rate further increases, are probably the one who are likely to fail, and it is much better to put them on invasive ventilation before they develop respiratory arrest. So the candidates who are fit for non-invasive ventilation are sick but not very sick. They should be basically COPD with acute exacerbation, and those patients who require short-term mechanical ventilatory support. Where should non-invasive ventilation be administered and by whom? In one of the studies, as you know that most of the time non-invasive ventilation is given to patient in the ICU setup. But if you understand the natural history of deterioration during acute exacerbation, the patient goes from early exacerbation to median exacerbation to late exacerbation. So if we can pick up this patient early in the general ward or in the respiratory ward and apply non-invasive ventilation, then, and if we have a trained staff in terms of resident doctors and the nurses, then many of these patients can be managed in the general wards or in the respiratory ward by giving effective ventilation at a stage when they have not deteriorated significantly. So if we have to look into the various aspects of non-invasive ventilation, the first aspect is that who should be treated, whether mild exacerbation, moderate exacerbation or severe exacerbation, and where should the patient be treated, general ward, emergency ward, high dependency unit or ICU. Now if you evaluate your patient and you find that the patient has got mild exacerbation and if his or her pH is more than 7.35, then it is better to treat them conservatively, because most of these patients can be oxygenated very easily, they are not acidemic, so you can give them a trial of conservative management. Mild exacerbation, but the pH goes down and patient becomes acidemic, the pH is between 7.3 to 7.35, it is better to put this patient on non-invasive ventilation, even though they can be managed on conservative means, but they still should be put on non-invasive ventilation. And these are the patients, I think, who can be managed in general wards, because they are sick but not very sick, and they can also be managed in the emergency units, in the casualties, provided we have the trained staff available with us. The moderate exacerbation, here the patient becomes more sick, there is a further increase in the PCO2, the pH has fallen from 7.3 to 7.25, and these are the patients, I think, who are comparatively more sick. They should be managed either in the high dependency unit or they should be taken to ICU. The next category, the severe exacerbation, once the pH is less than